Hello, this is Dr. Carol Motley, Associate Professor in Family Medicine here in Mobile at the University of South Alabama College of Medicine. The following webcast focuses on the theme of enhancing patient education. Why spend the time it takes to educate patients? There are several very good reasons. If you look at the causes of premature death in our country, the largest reason is unhealthy behaviors. 40% of premature death could be prevented by developing healthy lifestyles. Behavior can be modified, however. It takes the patient to be engaged and motivated to make change. Patient education about consequences of their behavior is the first critical step towards making change. This requires appropriate and targeted medical education. Sure, the patient knows they need to quit smoking, but what are the risks to continuing smoking? And how does one begin to stop smoking? The obese patient knows they need to lose weight, but most are unaware of the composition of a healthy diet or what a healthy portion is. The following projects that will be presented have focused on the most significant behavioral health problems in our country. Patient education projects such as these are critical to improving the health of our nation. These are projects that I believe should be continued and developed further. Seeing the hard work and dedication of these scholars leaves me with gratitude and hope for the leadership of the future. Please listen as they share their passion and commitment to making a difference for patients through their projects.
Hi, my name is Cami. I am a second-year family nurse practitioner student from University of California, San Francisco. I was placed at Wesley Health Center in Phoenix, Arizona. The title of my project is all about reducing salt. I basically did a survey on selected patients at Wesley to see what their beliefs, attitudes, and barriers were with regards to following a low-salt diet. The reason why I had chosen this particular project was because I feel that as clinicians, it is important to find out what sorts of barriers our patients face to help them stay on their regimen and make sure that they feel supported by us. In doing so, I found a validated questionnaire that was put together by a group of nurse researchers, the Dietary Sodium Restriction Questionnaire, or DSRQ. Most of our patients at Wesley speak only Spanish, so I had to have this questionnaire translated into Spanish and then back translated to ensure consistency. I targeted patients who were diagnosed with either diabetes or hypertension and were attending the health educational classes. Patients were provided this questionnaire packet either when they got checked in or during their class. They were also asked to complete this questionnaire and then turn it in at the end of their class session or when they check out from their clinic. Most of the items from this questionnaire used a rating scale from 1 through 5, and these items cover things like barriers, personal beliefs, and attitudes. Over a 2-week period, I was able to capture 20 participants. While this was a small sample size, I did find several interesting things. According to the survey results, 50% of these participants report that they try to follow a low-salt diet. And when asked about whether different barriers might have prevented them from following a low-salt diet, the average ratings really fluctuated, which meant that there is not a single universal barrier. With regards to questions that assess these participants' beliefs and attitudes, it appears that most participants want to follow advice from their doctor as well as their family members. Furthermore, participants generally recognize the relationship between eating a low-salt diet and health benefits. Like all studies, there are many limitations to consider, such as small sample size, literacy issues, and limited time. However, there are some recommendations I would make based on my project findings. First, all patients should be provided the DSRQ at the clinic. There is a recent study from 2012 showing that 99.4% of U.S. adults consume more sodium than what is recommended by the FDA. Second, treatment plans and educational sessions should be tailored to the patient's needs. It is also equally important to gauge their motivational level prior to putting them on a low-salt diet. Motivational level was not directly assessed in my project, but it would be very interesting to find out that piece. So that sums up my project. I look forward to a productive discussion at a colloquia. Thank you.
My name is Rafael Alonso Saldana. I'm a medical student at the University of North Carolina in Chapel Hill, class of 2017. This year I worked with the United Neighborhood Health Services of Nashville, Tennessee, under the supervision of my faculty advisor, Dr. Consuelo Wilkins. The title of my project is Assessing the Effectiveness of health educational posters in community health centers. The objective: with the intention to take advantage of the time that patients spend waiting to visit in clinics, this project employed visually attractive, quick response code equipped educational posters into patient and waiting rooms of the United Neighborhood Health Service clinics, aiming to increase patient knowledge regarding their own health, improve patient adherence to follow up visits, encourage dialogue between the patient and physician, assess the patient usage of QR codes. Methods: 10 patients were asked to evaluate posters by voluntarily filling out an anonymous questionnaire. The questionnaire aimed to gather patient demographic information and their feedback on the poster's content and effectiveness on meeting all four of the previously mentioned project goals, as well as whether they thought that the posters were visually attractive or not. Random patients of different backgrounds, ages 18 through 55, were asked to participate. All the QR codes were individually tracked for users. The tracking was done using QRStuff data analysis, a registered trademark of DensoWave Incorporated. This company tracked how many times each individual quick response code was accessed in a period of 1 week. Key findings: at this point of the project, there is not a big enough sample population to run accurate statistical analysis, but so far, the results indicate that a larger majority of people in the study thought the questionnaire was effective than not. The study also found that in 1 week period of the QR codes were tracked, United Neighborhood Health Service patients did not utilize them. Yet, 1 week is a relatively brief period and may not show the full potential of this technology. Recommendations: if future studies increase the sample size and broaden the categorical levels, more feasible results may be attained. In addition, quick response codes are relatively new technology that needs future research to determine efficacy in the community health centers setting. This pilot study demonstrated some challenges to using this technology. Although quick response codes do not take up a lot of space in the posters, are very easy to create and are a relatively new technology, and if they continue to grow in popularity, their usage may increase. All are reasons why the community health centers may want to consider them as a mode of health education.
Identifying Barriers, Interpreting the Edinburgh Postpartum Depression Scale for Refugees by Tiffany Smith. The objective of this study was to do an assessment of healthcare worker concerns in regards to the administration of the Edinburgh Postpartum Depression Scale for Refugees. The second was to identify obstacles that interpreters may encounter when administering the screener to the patients. The third was to do an assessment of the efficacy of the scale's ability to screen for depression and or anxiety with the refugee population. So in doing so, I developed 2 surveys. The first survey was for healthcare workers, just to discover their concerns or problems with the screener. The second survey was to identify challenges like culture or language or education that interpreters may face when administering the screener. The third tier of the project did a comparison of a non-refugee cohort versus a refugee cohort, all of which the patients scored 10 or higher on the screener, just to see if their outcomes were consistent. The key findings showed that the healthcare workers were not confident in the screener's ability to screen for depression for the refugees. Moreover, the interpreters replied that lack of education made interpreting this screener most challenging, and that it was actually the answer choices that were more difficult to translate than it is the questions, because the answer choices call for this quantitative response that may not be as apparent to the refugee patient as it would be to a non-refugee patient. And then interestingly, the screener showed that it had been just as effective in screening for depression and or anxiety with the refugee population as it did with the non-refugee population. Moving forward, an analysis should be done to investigate whether the patients that actually have been diagnosed with depression and or anxiety, but contrarily may have scored lower than 10 on the screener. This will show if the screener is effective in screening all patients and not missing any in the process.
Hi, my name is Danielle Pettiflores, and I was placed in Nashville, Tennessee at United Neighborhood Health Services, UNHS. I did a survey of breastfeeding awareness, and I wanted to determine if there was a knowledge deficit regarding current breastfeeding recommendations, as well as some of the benefits of breastfeeding. I also wanted to evaluate current breastfeeding rates among patients at UNHS, as well as their interest in increasing their knowledge of breastfeeding. My methods were that I surveyed 40 women of childbearing age. The survey consisted of questions about their past breastfeeding experience, whether or not they had breastfed, and their level of satisfaction around that breastfeeding experience, as well as their plans to breastfeed in the future, or if they did not have plans to breastfeed in the future. And the survey also contained 7 true or false questions about breastfeeding benefits and breastfeeding recommendations to determine if there was a knowledge deficit. The 7 true false questions were all worded in a way to be true. My findings. The average number of correct responses for the 7 true false questions was 3 correct responses out of a possible 7. 28 of the women had children, and 75% of those 28 women had not breastfed in the past, which is much lower than the national average. 72.5% of all the women did not intend to breastfeed in the future. There was not a statistically significant difference in average number of correct responses between women who intended to breastfeed in the future and women who did not intend to breastfeed in the future. Also, 75% of the women surveyed did not want any more information about breastfeeding. Recommendations. Expand the study by increasing sample size and diversity. My N was only 40. I had a hard time getting people to complete the surveys. The majority of the women surveyed identified as African American, and the majority of the women were surveyed at one specific health fair, which means they probably also lived in the same neighborhood. So this sample is probably not representative of the wider population served by UNHS. In addition to expanding the sample size, I also wanted to include more questions on the survey about the benefits of breastfeeding. I focused a little bit more on recommendations and also sort of myths around breastfeeding. I'd also like to educate staff and clinicians about breastfeeding recommendations and benefits. My sort of impression just from talking with folks who work at UNHS is that it's not a main priority among clinicians there or among the staff there. I could be wrong. I'd also like to increase knowledge of breastfeeding through actively promoting the benefits of breastfeeding. This could be done via posters, brochures, through clinician-patient interactions, lots of ways. Okay, thank you.